Okay, good day, good day. Welcome to a new class. Glad you guys are excited to be here. Hopefully you guys saw the case already today. If not, that's fine. We're gonna make sure that you will cover it here and review it before we get into the breakdown here. While we're waiting for everyone to kind of pile in here, we'd love to know where you're all from. Go ahead, throw that in the comments, where you're watching from right now, where in the world are you, and then we're going to get started in a couple minutes here. So go ahead and do that. Let me know where you're at, and we'll do a little bit of a sound off there, and then we'll get started. Where are you all from? Libya. Nice. Pakistan. Canada. Bulgaria. Canada. India. Right on. Kentucky med student. Right on. Scotland. London. Vancouver. Love it. Northeast Texas, Toledo, Bhutan. Right on. This is great. I love seeing this. It's kind of my favorite thing. That's why I do live classes, or at least part of it, is just to see where you're all from. There it is. Make sure that the tracking on the board is working. Okay, so let's get into today's breakdown and talk about how we can manage this patient. This one's a tricky one because we kind of focused on less the bleeding stopping. Yeah, it is pretty cool to see some African countries here. I love it. It's less about the bleeding control and more about what we should do after we've got control. And so that's what we're going to cover today, which is kind of exciting. So let's get into today's breakdown. Okay, just so you guys know, if you haven't seen me before, if you're popping in here like, who is this guy? My name's Geoff. I own a company called Medics. And Medics has been known to help thousands and thousands of EMT and paramedic students get through school. We also partner with schools and provide curriculum and education for them to provide to their students. So we actually partner with schools as well in order to provide them our very visual education in order to help their students. I mean, right now we have an over 94% success rate. So students that work with us, they get through their exam 94% of the time, which is one of the highest percentages that's been reported of any type of student resources. So that's what we're really proud of. And so if you're a student, you're struggling in school, you're getting past your exams, whether it's in Canada, the United States, or even overseas, we have a membership for you that has any type of topic that you could possibly think of inside our membership. And you can check that out for free on a 3-day trial. See if it's for you. If it is for you, stay as long as you like. If it's not for you, you can cancel anytime, no problem at all, but it's there for you to get ready. We also offer continuing education, and yes, you can get credits for these case studies as well. All right, let's get into today's case. So you are dispatched to a male patient who has a severe bleed to the neck. Okay, he looks like he was on a quad or a motorbike. So this typically happens. This is not an uncommon call where they actually get caught on like wire, barbed wire, and end up causing significant lacerations. So you managed to get this bleeding under control, so that's good news. But he has lost a significant amount of blood. And I'll show you the video shortly. This is a stage scenario. This is not a real patient that we actually shot ourselves at Medics. Your patient appears to be altered and fatigued. So those are pretty good indicators of what? Go ahead and put that in the comments. What is being altered and fatigued a pretty good indicator of in a trauma patient? What do you think? Any ideas? Go ahead and put those in the comments. Hypovolemic shock, brain is not getting O2, they're in severe shock, hemorrhagic shock, hypovolemia. I 100% agree with you. I think that these are very good indicators outside of vital signs that tell us that this patient appears to be altered and fatigued, showing that they are in a significant state of shock. That's a good indicator of that. So excellent. It's a good start. So let's take a look at this patient, see how he looks here. Okay. So we see that there's quite a bit of blood on the shirt. They're getting the helmet off here. It's hard to see, kind of get an assessment of this patient right now. The helmet needs to come off in order to manage that. We're going to show you the vital signs in a sec, but I want you to get an idea of what he looks like once we have the helmet off. And this is like, you can see that he's cold. He looks afraid. His eyes are closed. He's not really with it. Like, he's obviously altered. And so that gives us a pretty good indication that we have a patient that we need to deal with immediately and start to manage some of these things. Okay, so that's the first thing to give us an indication that we have a pretty sick patient on our hands here. So let's take a look at these vital signs. Okay, you have a heart rate of 159. It looks like they're in a sinus tachycardia. Blood pressure is 76/47. Now, a lot of the time, you'll need to kind of rely on your map. It's going to be your most accurate reading, and in this particular case, map is 56. Your ETCO2 is 27. This is significant findings, so definitely something that we need to take in consideration. Breathing rate is at 24 right now, and SpO2 is 94%, so it doesn't sound like we have any ventilation or oxygenation issues from an SpO2 standpoint, but we certainly are seeing an elevated respiratory rate, very likely due to the compensated or the decompensated shock that we see here. And temperature, I threw it in here because I want you to keep an eye on it, is 35.2 degrees Celsius. That is below our normal temperature. So that is an important thing to take in consideration in a patient with shock. Okay, so based on what you see here, is this patient in a compensated or a decompensated state of shock? Go ahead, put that in the comments. Is this a compensated or a decompensated state of shock? Mitchell thinks decomp. Okay, let's see here. ETCO2 is too low. He's going into shock. What kind of shock? What do you think? Decompensating. I agree with you, Mike. Decomp. Okay. This is a decompensated state of shock. Okay, decompensated state of shock. So how do I know that? Well, let's look at these vital signs here. Okay, I'm just going to back up just so we can see them. So this patient is in a decompensated state of shock. How do we know that? Well, he is compensating. Okay, so that's the first part, is that he's lost a lot of blood. So he's in a hypovolemic state of shock. Okay, so he's compensating for that. His heart rate is elevated, his breathing rate is elevated. So he's in a compensated state of shock. Okay, however, after we know that he is compensating in some way, okay, or his compensation factors have kicked in, being his elevated heart rate and his respiratory rate is increased, now we need to say, okay, are these compensating factors working? Are these compensating factors working? And the way to determine that is that the compensating factors, their job is to maintain perfusion. And so, judging by what we see here with elevated heart rate and the elevated respiratory rate, they are compensating or trying to compensate, but their body is failing at that task. So this would be suggesting that they have compensation factors kicked in, but they're failing. So in this particular case, they are in a decompensated state of shock, regardless of what their heart rate and their respiratory rate are trying to do. So this is a decompensated state of shock, and a pretty advanced decompensated state of shock. Okay, so what's the main issue when we have a hypovolemic state of shock, or what's the physiology behind it? Well, it's kind of twofold. We have, come here. I'm using a new computer, so bear with me as I navigate this. I had them, but they disappeared on me. Nope. Aha, I found them. Okay, so what do we have an issue here with? Basically, we have, this is kind of how we determine our mean arterial pressure is cardiac output by your systemic vascular resistance. Systemic vascular resistance is the amount of pressure against the vessels, the fluid pressure against this. It's just like any other type of pipe with fluid in it or air in it. It's basically the pressure against those vessels. When we have a lack of blood, okay, we have a loss of blood, then what essentially happens is that you're going to have a decrease in systemic vascular resistance because if without fluid, we can't put pressure against the walls of this vessel. So we have a decreased systemic vascular resistance. On top of that, we have a cardiac output issue because if we have no fluid, we have no ability to maintain preload. And so preload is decreased, which means that we have a decreased cardiac output as well. And so both of these things combined, because of the lack of fluid, we have our decrease of mean arterial pressure. Now, yes, we have compensation. We have the fact that our body will try and vasoconstrict in order to compensate for the lack of vascular resistance. We're going to have the heart rate increase, and we're going to squeeze harder on that blood that's inside the heart, which is going to improve cardiac output. Those are your compensation factors. But ultimately, without fluid, it doesn't matter how much compensation you have. Without fluid, you can't comprehend or compensate for that lack of, okay? You can't compensate or push against or combat that if you have no fluid in order to combat with, okay? So that's where we have an issue here with cardiac output and systemic vascular resistance, ultimately causing a decrease in our mean arterial pressure. Okay? So now that we know the pathophysiology, I'm going to introduce you to something that you've probably seen before. Okay, and that is the lethal diamond, or the diamond of death. There's a few different names for it, but the lethal diamond is what we're going to kind of talk about here. Now, that lethal diamond is acidosis, coagulopathy, hypothermia, and hypocalcemia. These four things are going to combine in order to cause cell death and patient death in your trauma patients. And so we're going to try to avoid these four things in treating our patient. And so there's some very basic things that we can look at right off the bat. Okay, we can look at a patient that is outside, decompensating, altered, okay, and we saw that they're cold. Okay, even though it might be a summer day out, they can still be cold because of the state that they're in. And so hypothermia is something that we can hopefully try and correct very quickly. And getting a patient warm, okay, is an important thing when it comes to coagulopathy and ability to clot. Okay, and so by heating them up and keeping them warm, we're actually limiting the amount of breakdown of clots that's going to occur. So this is a big part here, is that when you have a patient outside, you're going to be spending some time outside. Get them warm, get some blankets on them, get them as warm as we possibly can, and keep them from a hypothermic state, because it's going to help with a lot of other things that are going on here. So stay warm. Okay, acidosis is a tricky one. Now you're fighting against the clock here. You have a patient that's hypoperfused, and when a patient is hypoperfused, they progress further into acidosis. And so by improving perfusion, we can improve or limit the decline into more acidosis. Okay, so we're going to improve our MAP, and this is going to help with the acidosis. Okay, coagulopathy, there's a few things that improve coagulopathy. First off, limiting the amount of isotonic fluids you give someone. The heat and keeping them from hypothermic, that keeps improving coagulopathy. And this one right here, hypocalcemia. Over 50% of patients that have massive blood loss are also hypocalcemic. And so these patients have a severe stunt in their ability to clot. And so a patient that is hypocalcemic is also going to have problems with coagulopathy. And so those three things are going to be having a big impact on the ability to clot and stopping that bleeding from progressing. Okay, so those are the big things that we need to be focusing on. Heat, limiting acidosis, making sure our patients are hypocalcemic. And I know in an emergency setting that might be difficult, but again, a large portion of patients that have massive blood loss are hypocalcemic. So we might see a more proactive approach to introducing calcium in trauma patients in the future. Okay, and then all will help with the coagulopathy. Okay, so that is kind of a is this an upgrade on the trauma triangle? Yes, this addition, this hypocalcemia, is the addition to that. Okay, so let's talk a little bit about the treatment. Okay, so based on what we know, we've stopped this bleed. Okay, and we've controlled it, so we're not too worried about that. Let's talk about the blood loss portion, or the fact that he's lost a significant amount of blood. Let's talk about that resuscitation point. So what treatment would you like to start with after you've stopped that bleed? Okay, what are some things that are going to help this patient based on what we know so far? Go ahead and put that in the comments. What do you think? TXA, okay, fluids TXA. What else we got here? Stop the bleed, okay, we've got that. What else? Anything else? What else could we do to help with this patient? Passive rewarming, I'm up for that. I would say aggressive rewarming, not even passive, just warm them up. Get them as warm as you can, because hypothermia is no-go for these guys. Whole blood would be best. Okay, we're going to talk about blood products for sure. I love whole blood. Permissive hypotension with conservative boluses, love it. Whole blood, IV fluids, you guys are filling up the comments. I love this. Okay, so FFP, sure. And we're going to talk about FFP and platelets as well. Okay, so let's talk about, let's start at the beginning. Okay, let's start at the beginning. So what are we starting with? Well, we have a patient that is in a decompensated state of shock. Okay, they have a MAP below 65. They even have a MAP below 60. Okay, so we're going to have to supplement with some fluids. I'm not a big fan of giving fluids in trauma patients. I think it's important to limit them as much as you can, because the evidence shows that they're not a huge benefit. But in this particular case, we don't have access, typically don't have access to blood as soon as we arrive to a massive transfusion patient. We have to request it. And so the idea in this particular case is that we're introducing fluids to maintain a MAP of 65 to essentially buy this patient time until they can get blood. Okay, so that's the first thing, is that we're going to introduce fluids to get their, maintain the MAP of 65 to buy this patient time until they can get blood. Okay, that's what we're going to do with those fluids. The next thing is TXA. Now, the evidence coming out with TXA lately hasn't been amazing, okay, to say the least. So here's my little thought on TXA. What we know so far about TXA is that the biggest benefits we get from TXA is when we give it early and large enough boluses. Okay, so early is the key piece here. The earlier we give it from time of incident, the better chance it has at benefiting our patient. That's all we know. As far as how good it is, we really are in a flux of how good TXA is. We used to think it was a super drug. Now we're thinking it's coming back to or Mother Earth kind of idea, right? So we're kind of in this little flux of how good TXA is. We know it's good for pre-hospital postpartum hemorrhages, but as from a trauma standpoint, we know it's okay. We know that it's okay from in a head injury standpoint, but we just don't know how amazing it is. The answer is it's probably slightly better than nothing. But what we do know for sure is that it has more efficacy and more benefit to a patient the earlier it is given, which means that it is a usual or a common pre-hospital medication that we give in blood loss situations and injury situations like this. So is TXA this wonder drug that we thought it was? No, but it is a benefit the earlier it is given, and so that means that it is forefront in EMS. Okay, so those are the two things you're probably going to start with. Okay, and this is assuming that you have your airway controlled and you're oxygenation controlled and so on and so forth. Okay? Next. Here's my next question, which I think I know is going to be fairly unanimous, but does this patient require blood products? Based on what we know, does this patient require blood products? Let's see. What do you guys got? C. I love it. Absolutely. Yes. 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 Don't see a no yet. I agree. Okay. I think that this patient absolutely requires blood products. Now, one thing that I like to mention in these situations is why. Okay. Why does this patient require blood products? Is it because he's lost a lot of blood and we need to replace that? Or is it because he's in a decompensated state of shock? What are the things that are telling us this patient requires blood products? And there's a few things in the vital signs that can tip us off to that. It might be an answer or an obvious answer to you, but it's always nice to have some evidence to back it up as to if you were ever questioned as to why you requested blood products, this is the kind of things that you can look at. Okay, first off, you can look to see if they've had a 30-point increase in a baseline heart rate. Okay, 159, is that above a baseline heart rate? Pardon me, I'm sorry. Is that above a, is that a part of a usual baseline on a heart rate? Absolutely. 30 points, 100% it is. Okay, it's way above that. Do we have a 30-point drop in our systolic blood pressure from normal? Absolutely. Okay, those are two things. So think of the rules of 30, and those are the two things that you think about. Okay, do we have a 30-point increase in our heart rate? Yes. Do we have a 30-point decrease in our blood pressure? Yes. There was also a study that came out of the military looking at end-tidal CO2. So when you have an end-tidal CO2 in a trauma patient that is below 28, this was highly suggestive of requiring blood products because a low EtCO2 like this is suggestive of poor pulmonary perfusion. And so this patient requires blood for a few different reasons. We have an elevated heart rate above 30 points. We have a decrease in systolic blood pressure below 30 points. And we also have a significantly declined EtCO2 below 28, which is highly suggestive of required blood products. So if you're ever questioned, those are the things that you can think about. Okay, so that is your talk about blood products. So does this patient require them? Absolutely. So let's talk about how that works. Now, there's a big push with whole blood, and I'm with the idea of whole blood. I think it makes way more sense to do whole blood from an EMS standpoint. Okay, I don't think there's any question. So when it comes to the traditional way of doing blood resuscitation is that we use a 1-to-1-to-1 ratio. That means one of your red blood cells, one of your plasma, and one of your platelets. Okay, 1-to-1-to-1 ratio is typically what we do in a traditional resuscitation standpoint. Okay, and so, however, in EMS, there's been a big push into just using whole blood as opposed to having the 1-to-1-to-1 ratios that would give you the full components of blood. What we're really looking at lately is just using whole blood in EMS. And the reason being is that it's a lot easier to manage, and it's a lot easier to kind of basically have a complete set as opposed to having to manage different components. We're just going to be using whole blood. But what's interesting is a lot of people are saying, hey, well, I mean, whole blood's hard to get, and whole blood's, this is just the beginning. You get into getting into EMS at a very different point. I'm kind of mid-career, if not like closer to the end of my career in EMS, and more like mid-career. But I digress. So my point I'm making is that we're just finding out, in the last 5 years, we're just finding out that whole blood is kind of the gold standard. And typically, it's going to take 10, 15 years in order to innovation to catch up to what we know is the gold standard. And so we know that, yeah, right now, whole blood is very difficult to acquire, and it's expensive. But there's also a lot of innovation that's happening around blood products. In fact, a dehydrated blood products that have longer shelf lives. You just simply add fluid to it and you have your volume expander with components. Like, that's legitimately a thing that is being created right now, is a dehydrated blood products that just you need to add fluids to, and then you have a full component blood product that you can give to patients. Pretty fantastic. So as difficult as it might be right now to get your hands on whole blood and have whole blood systems, there is some fantastic, fascinating innovations that are happening in EMS right now. And one of them is dehydrated products that we just rehydrate, and there you go, you have yourself blood products, which is amazing. So yes, I know that it's kind of a sticking point of, oh, we can't get blood, so we might as well just use fluids. There is some saving grace coming with the amount of innovation that's happening. So pretty cool. So that is kind of my talk about blood. I'm going to get to your questions in a sec here. And so the last thing is that hypocalcemia. Now, I mentioned earlier in the class is that this hypocalcemia, it's typically found that about 50% of mass blood loss patients are hypocalcemic, and calcium has a major role in clotting. So when it comes to should we be correcting this, right now the standard is if your patient is hypocalcemic. So if you actually have an ability to do an ISTAT, or if you're picking this patient up from the hospital and they did blood work and they found them to be hypocalcemic, then we would introduce calcium. That's kind of what the standard is now, even in my practice with flights. Typically, we're giving calcium when we have confirmed low calcium or hypocalcemia. But I believe in the future, we're going to be more proactive with this, because having a higher than normal calcium for a short amount of time is not a bad thing in these patients. And so I think that we're going to look at kind of like a benefit to risk factor, given if this patient is likely to be hypocalcemic, which a lot of mass blood loss patients are. I wouldn't be surprised if we have calcium as part of our protocols in a proactive mass blood loss protocol to give calcium because of the likelihood that they are hypocalcemic. So should calcium be part of this? I think we're going to really see a big push for that in the future, in particular with trauma patients that have had massive blood loss. So that is my thoughts on calcium and if we should give it. Right now, I think when we have confirmed hypocalcemia, absolutely. And then I think in the near future, we're going to start to see calcium become a big player in mass blood loss, even when we don't have confirmed hypocalcemia. Okay, any questions at all? Yeah, Austin Travis County is doing whole blood products. So there are a lot of rural EMS in North Carolina. I agree. Blood products are becoming a lot more common. Again, like I said, when things become the gold standard, all of a sudden innovation becomes a big thing, right? And so we're going to see more and more of this as we go. Pressors. I know something we would consider in practice, but would whole blood cost less than components? I believe that whole blood is more expensive up front, but long term, because you have to store it and manage it, I believe that whole blood becomes cheaper from a logistics standpoint, from a shelf life standpoint, but I could be wrong about that. Pressors. Okay, so let's talk about pressors for a second. There have been some studies about using vasopressors in mass blood loss patients. The studies were underwhelming. And so should you use them in supplementation? I think that the only one that really makes a lot of sense is potentially norepinephrine. I don't think that there is a huge benefit in any of the other ones, really. Maybe epinephrine, but again, you're getting so much of that beta and if there's no point really increasing beta if you already have an elevated heart rate, plus you have no fluid in there, you have no blood in your in your heart. And so you could improve systemic vascular resistance and cause vessel squeeze in order to improve preload and blood return back to the heart. So in theory, they make sense, but unfortunately in practice and in study, there hasn't been a massive difference between them. So I think that the answer is that if you need them, then norepinephrine is your best choice in these situations. But just understand that you might see a very temporary boost in their blood pressure as opposed to a long-term one because of the lack of blood. What they need is volume expansion. They need blood expansion is what they need. But can norepinephrine buy them time? Maybe for a very short amount of time. But remember that vessel squeeze and that tightening and that active process requires perfusion. It requires muscle flow. And if you are lacking that, then your compensation of that is going to be very limited. In fact, in late trauma, we actually have vessel dilation because we have an inability to maintain vessel squeeze anymore because it's an active process. And so there's a theory too that you may speed that process up of getting to that late stages of shock by using pressors and not introducing blood early enough. So there's a lot of risk-benefit things here that we just don't know if the benefits outweigh the risks. But as of right now, in my protocol, there is no norepinephrine in my protocol, but typically it's after we've introduced blood products. What interventions would aid in the ETCO2 improvement? Best thing to do in that particular case is improve perfusion. So blood products, some fluids to maintain a MAP of 65. Those are the kind of things that are going to improve your ETCO2 because that low ETCO2 is due to a lack of pulmonary perfusion, lack of blood flow through the lungs. And so in order to improve that, we need to improve blood flow through the lungs. Best way to do that is improve perfusion, systemic perfusion. All right, anything else? All right, so like I said in the beginning, in case you missed it, if you guys are students or you're struggling in school, in EMT school, struggling in paramedic school, and you want help, that's what we do. We specialize in EMT and paramedic education in our membership. And so you get access to all these case breakdowns, you get access to any type of visual course that you're looking for, anything from cardiac to respiratory to ETCO2 to vital signs to assessments, everything, including operations. We do a course on that in order to help you get through EMT paramedic school. And of course, we do exam preparations, including coming up right away, the new style of exam questions that the National Registry is running. And so we have a very high success rate with our students that go through our exam preps. So if you're interested and you want some help, want someone to have your back getting through school and getting through your exams, there's very few out there that have a better success rate than us, if any. So we would love to have you there and to work with you through that and make school way less stressful for you. So you can check it out on a 3-day trial as well. Check it out for free. And if it's for you, stay as long as you like. If it's not, you can cancel at any time. Okay, so I'll let you go from there. Thanks again, and we'll talk to you next time. Bye for now. How much is the program? It's about $21 a month, US. So you can check it out, the link in our bio there.